Bismillahirrahmanirrahim. Today we will discuss the anatomy of the nose and the paranasal sinus, and we will give some hint about the investigation in the rhinology. About the anatomy of the nose, nose is divided into two parts, external nose and nasal cavity. The external nose is the part of the nose which gives the shape of the nose. It's formed by two parts, upper third, which is a bony part, and lower two third, which is a cartilaginous part. As regards the bony part, is formed by three paired bones on each side. The first is nasal bone proper, articulating with nasal process of maxillary bone and the nasal process of frontal bone on each side. This part of the nose, external nose, which could be fractured, and this part which we can do and what's called osteotomy. We can fracture this either by osteotome during rhinoplasty to do what's called a rhinoplastic surgery. So it gives the shape of the nose. As regards the lower two-third, the cartilaginous part. This cartilaginous part gives the flexibility and the malleability of the nose to resist the trauma. And this part is also responsible to support the airway. Also, it is malleable and flexible, but it gives support to the airway to prevent a collapse during inspiration. So it's a very important part. The cartilaginous part is formed by two parts. The upper lateral cartilage, which is forming the middle third of the nose, the lower lateral cartilage, which forming the what's called the nasal tip. The sulcus vestibuli, which here by the blue arrow, is dividing the lower lateral cartilage from the upper lateral cartilage. Regarding the lower lateral cartilage, it's forming what's called the nasal tip. This nasal tip, we need to know some anatomical hints about it, because in the nasal tip we have the anterior opening of the nasal cavity, which is called the nostril. It's surrounded medially and medianly by what's called columella, which is the median part of the nasal tip, and laterally on each side but what's called the ala of the nose. So we have the ala of the nose, we have the columella. So this is what's called the defining tip point, or the tip of the nose, or the lower lateral nasal cartilage. Second part of the nose is the nasal cavity. We need to study the opening of the nasal cavity, the walls of the nasal cavity, and the lining of the nasal cavity. Regarding the opening of the nasal cavity, we have two openings, anterior opening and posterior opening. The anterior opening is called the anterior nares or the nostril. We discussed this before in the nasal tip. And the posterior nasal opening is called the choana of the nose, and it communicates between the nasal cavity and the nasopharynx. The dimension between the anterior and posterior opening, or the anteroposterior dimension in adults, is about 7 centimeters. And that's why the nasal cavity is much larger than the external nasal dimension. Regarding the surface lining of the nasal cavity, all the nasal cavity and even the paranasal sinus, which is the maxillary, ethmoidal, sphenoidal, and frontal, are lined by respiratory epithelium, which is columnar, pseudocolumnar ciliated, stratified with goblet cell. That means that all this mucosa secrete mucus from the goblet cell, and it is moved by the ciliary movement all over the sinus wall and the nasal cavity posteriorly toward the choana to reach to the nasopharynx, and we can swallow all this mucus, which can reach to up to 1 liter per day without any interference. So this is the most lining of the all the nasal cavity and the paranasal sinus, except two areas. The exception in the vestibule, which is the area in the nasal cavity opposite to the sulcus vestibuli outside. It is lined by, this area of vestibule is lined by skin with hair called vibrissia. So it is lined by stratified squamous keratinized epithelium with hair. The other exception is in the roof of the nasal cavity, which is covered by olfactory epithelium. And this is very important because the olfactory epithelium is near to the nasal roof to reach to the anterior cranial fossa. Regarding the wall of the nasal cavity, we have roof, we have floor, we have lateral wall for each nasal cavity because we have two nasal cavity. So we got a roof and floor and lateral wall for each nasal cavity, but we have only one medial or median wall, which is the nasal septum. Starting with the roof of the nasal cavity separates the nasal cavity from the anterior cranial fossa, the dura, the CSF, the brain. So any injury in the roof can lead to what's called CSF rhinorrhea. The roof of the nasal cavity is formed by the body frontal sinus, cribriform plate of ethmoid, and the sphenoid body. The floor of the nasal cavity is formed by the hard palate, which is formed by maxillary bone in the anterior 3-4, and the most posterior part is formed by the palatine bone. This hard palate separates the nasal cavity from the oral cavity. Regarding the medial wall of the nose, which is formed by the septum, which covered by mucosal flap on each side. The septum is formed by four parts. The first, which is the anterior inferior part, is the septal cartilage, which gives the malleability also of the nose. We can move the lower part of the nose freely, and it's freely mobile because it's formed by cartilage or over by cartilage. So it's called septal cartilage quadrilateral cartilage because it's similar to the quadrilateral. Got a very important point, which is 1 centimeter posterior to the columella, called by the Little's area. Little's area we will discuss later when we discuss the blood supply veins. It articulated posteriorly, superiorly with the perpendicular plate of ethmoid, which is a very thin bone articulating with the cribriform plate of ethmoid. It's very harsh, very tiny bone. If we do any harsh movement, you can do injury to the cribriform plate of ethmoid and CSF leakage. In contrast to the posterior inferior part, which is formed by the vomer, which is a very, very thick bone. We cannot remove it by simple maneuver. We need hammer and gouge to remove this thick bone. The septal cartilage and the vomer are fixed in the nasal floor in what's called maxillary crest. Maxillary crest is a grooved, tunneled bone which all over the nasal floor, it fixed the septal cartilage and the vomer. So this is the part of the nasal septum. Then we come to the lateral wall of the nose. Lateral wall of the nose is formed by defined by three bony shelves in the dried skull, which called the concha. We have inferior concha, it's from the maxillary bone, middle and superior concha from the ethmoidal bone. But in the living human, it is not dried bone. It's covered by muscle, by blood vessel, by mucous membrane, by nerve. So it have another name. It's called turbinate. We have inferior turbinate, middle turbinate, superior turbinate. So this is the name, turbinate. Turbinate from turbulence because we need to do a wave. We in the nasal cavity is not just a nasal tube passing the air. No, we need to do a wave to do the function of the nose, which is the air condition, the main air condition of the body. It is change the temperature, change the humidity. It clears the air, filtering the air, like the air condition. So the air need to pass through the nose. And if you want to know the function of the nose, you can try to breathe from the nose and breathe from the oral cavity, and you will know why the function of the nose is very important. And that's the function of the turbinate. It makes these waves. So it is the name of turbulence. Of course, if you need also to smell, you need to make a wave to get the air up into the olfactory mucosa, and that's why we do sniffing, if because we need to smell something to increase the turbulence, and that's why we call this turbinate, inferior, middle, superior turbinate. Below each turbinate, we have what's called meatus. It's a cavity below each turbinate, which received important structure. Uh, for the inferior meatus, it only received what's called the nasolacrimal duct. The nasolacrimal duct is the only important structure in the inferior meatus. It's 1 centimeter posterior to the anterior end of the inferior meatus. But the middle meatus and superior meatus is a very important structure, and it's called the key area for endoscopic sinus surgery. Why? Because it received the natural ostium. Natural ostium of the paranasal sinus open in this area. So if you need to do a surgery and retain the function of the sinus, you need to clean the sinus from its ostium, because as we discussed earlier, all the mucus directed through the cilia towards the natural ostium. So if you open the sinus away from its natural ostium, it will not be cleared. All the natural ostium in the middle meatus and superior meatus. So it is the key area for scopic sinus surgery. What is the important structure in the middle meatus we can discuss? What's called the osteometer complex. Osteometer complex is formed by three structures: hiatus semilunaris, uncinate process, and bulla ismoidalis. At first is the uncinate process. Uncinate process is a semilunar bone. It have an anterior attached margin and posteriorly freely mobile semilunar margin. This is the first thing to we can face in the middle meatus. Posterior to the uncinate process, we have a bulge like a balloon. It's called bulla. It is in the anterior ethmoid, so it's called bulla ethmoidalis. Bulla ethmoidalis. It is the largest anterior ethmoidal air cell. Between the bulla ethmoidalis and the uncinate process, there is a hiatus, a depressed shallow tunnel. It is similar to the posterior margin of the uncinate, so it is a semilunar in shape, so we call it hiatus semilunaris. This hiatus semilunaris receives the opening of the anterior group of the paranasal sinus, namely frontal sinus, anterior ethmoidal sinus, and the maxillary sinus. Superior meatus receives the opening of the posterior ethmoid, whereas the sphenoid sinus open in what's called a sphenoethmoidal recess. Regarding anterior ethmoid and posterior ethmoid, as you can see, the anterior ethmoid is in the middle meatus and the posterior ethmoid in the superior meatus. What the bone separate each part is called the ground lamella or basal lamella, as we can see by the arrow, by the blue arrow. It is a very thin bone. It can be removed easily by the sucker during endoscopic sinus surgery, and we can open the anterior and the posterior ethmoid if we just remove this ground lamella or basal lamella. Regarding the blood supply of the nose, we have arterial blood supply and venous drainage. Arterial blood supply of the nose have an important relation that external carotid and internal carotid have an anastomosis in the nasal mucous membrane. So we have a branch from the external carotid and the branches from the internal carotid. Regarding the branches of the internal carotid, it comes from the ophthalmic artery, which get into the orbit with the optic nerve through the optic canal, give two branches, anterior ethmoidal and posterior ethmoidal artery. It passes through the medial orbital wall to the lateral nasal wall, to give blood supply to the nose above the middle turbinate. Then it go up to the brain to re-enter into the cranial cavity and then go downward along the nasal septum to give blood supply to the upper part of the nasal septum. The anterior sigmoidal is continuing downward till reaching the little's area, whereas the posterior sigmoid doesn't share with the littles in the little's area. Regarding the branch of the external carotid, we have three branches: sphenopalatine artery, greater palatine artery, and superior labial artery. Sphenopalatine artery is responsible for 70% of the blood supply of the nose. It comes from the maxillary artery, terminal part of maxillary artery in the pterygopalatine fossa. It passes to the nasal cavity in the lateral nasal wall in what's called the sphenopalatine foramen, which is posterior to the middle turbinate as shown by the blue arrow. It gives 70% of blood supply of the nose. That means all the lateral nasal wall below the middle turbinate. And also it gives a septal branch which pass along the anterior wall of sphenoid, then go U-turn and go along the nasal septum anteriorly to give blood supply to most of the nasal septum till it reach to the little's area. It have another name which is called the artery of hypertension, and it is responsible for what's called the posterior epistaxis. As you can see, the sphenopalatine foramen is very close to the guana. So if any bleeding occurs, especially during the hypertension with old age patient with severe hypertension, he presented to us with posterior epistaxis because this artery is very near to the guana. The other branch coming from the maxillary artery is the greater palatine artery. This greater palatine arteries come from the floor of the pterygopalatine fossa. It passes through the greater palatine foramen, which is situated on each side of the last molar teeth, to reach anteriorly till it reaches to the incisive canal and pass upward through the incisive canal to reach to the nasal floor. So as it's very obvious, it supplies the nasal floor. The last branch is the superior labial artery or the facial artery, which is responsible for the blood supply of the nasal tip. All blood supply of the nose is terminated in the little's area except the posterior sigmoidal artery, and that's why there is a huge blood supply to the nose, and this is important for the function of the nose. Each artery of this is a very important artery. If any minute injury occurs to this artery, a severe epistaxis can occur. The huge blood supply of the nose is responsible for its function because it heats the air in the cold weather, or it cools the air during the hot weather through vasoconstriction and vasodilatation, as we will see after this. Regarding the venous drainage, it has the same name of the artery. The ophthalmic drain the anterior sigmoid and posterior sigmoid. The trigoid plexus of vein drain the greater palatine and sphenopalatine. But it have a very important criteria, which that is that this veins is valveless, so it is supposed we can get what's called retrograde thrombophlebitis and what is called cavernous sinus thrombosis. So the nose is the part of the dangerous area of the face. That's why, because a valveless vein drainage. Regarding innervation of the nasal cavity, we have somatic innervation through trigeminal nerve branch, namely maxillary nerve and the ophthalmic nerve, which have similar name to the artery. It's responsible for sensation. We have also special sense supply nerve innervation through the olfactory nerve through the roof and the upper 1 centimeter of the nasal mucosa. What I mean, the mucosa above the superior turbinate and the roof of the nose and the upper 1 centimeter of the septum. The last innervation is the autonomic innervation. It's very important because it is responsible for the autonomic function of the nose. It's formed by parasympathetic and sympathetic supply. The parasympathetic is through the greater superficial petrosal nerve of the facial nerve, and the sympathetic through the deep petrosal nerve, which come from the carotid plexus. Both nerve united to form what's called the Vidian nerve. So this autonomic innervation is very important to control the diameter of the blood vessel, to control the secretion of the mucus from the goblet cell, to control the movement of the cilia, It's very important to the nasal function. Regarding the lymph drainage, the anterior part of the nasal cavity is drained through the submandibular lymph node, whereas the posterior part of the nasal cavity is drained through the upper deep cervical lymph node and the retropharyngeal lymph node. We'll discuss the anatomy of the paranasal sinus. Paranasal sinus are air-filled space in the skull bone lined by respiratory mucus, which is columnar pseudostratified columnar ciliated with goblet cell, which secrete mucus moved by the mucociliary clearance toward the natural ostium in the lateral wall of the nose, in the middle meatus and superior meatus, to drain through the nasal mucus ciliary clearance toward the guana. We have four pairs of sinus: maxillary, ethmoid, sphenoid, and frontal. The ethmoid is subdivided into anterior ethmoid and posterior ethmoid. During birth, we got only small maxillary sinus and small anterior ethmoidal cell. All other sinus will develop later during life, and even 10% of population will never have a frontal sinus. As you can see, there is an important relation to the sinus, namely the orbit, which is forming the lateral relation to the ethmoidal sinus and sphenoidal sinus, and the superior relation to maxillary sinus, and the brain, which is forming the skull base here by the ethmoid. It separates the brain from the ethmoid sinus and sphenoid sinus, and even the posterior wall of the frontal sinus. So it's a very important relation, and any maneuver in this sinus, if not seen well, it can lead to a very dangerous complication. Frontal sinus is absent in 10% of population. It developed after 1 year of age. It's not in the newly born child. It's ostium, drainage ostium in the floor of the sinus. So it is dependent on gravity, and it is responsible for the vacuum headache, which is a very common headache for sinusitis, which start early in the morning after wake up. Why? Because there is accumulation of the discharge during sleep. So when you get up early, you feel the headache. After 1 or 2 hours, the headache relief. Also, it increases leaning forward during pray. So it is increased by gravity. So that's why it's called vacuum headache. Relation of the frontal sinus anterior to the forehead, posterior to the anterior cranial fossa, inferiorly to the floor, to the nose and the orbit. The ethmoidal sinus is not a cavity with a one ostium. No, it is formed by air cells, with each ear cell have its own opening, and this all opening is drained into the middle meatus for the anterior ethmoid and the superior meatus for the posterior ethmoid, which is separate from each other by grana lamella. The anterior ethmoidal ear cell is numerous in number but small in size. It may be reached up to 8 up to 12 in number. In the contrary, the posterior ethmoid are larger in size but fewer in number. Could be only 2 posterior ethmoidal cells, maximum 5, but the size are more larger. The important relation of ethmoidal sinus is the roof related to the skull base and the brain. The lateral wall is related to the orbit, namely the medial wall of the orbit, which is formed by what's called lamina papracia. The paper bone is a very, very weak bone, and that's the problem during ethmoidal surgery. You need to be careful not to injure the brain or not to injure the orbit. Also, the posterior ethmoid is directly related to the optic nerve, and that's why it's a very dangerous area to work if you're not expert enough. Sphenoid sinus is situated in the body of sphenoid. It have a very important relation. It related anteriorly to the nose, inferior to the nasopharynx, Its roof is formed what's called by sella turcica, in which the pituitary gland is situated, and laterally it is related to the cavernous sinus with its content, and the optic nerve above, and the carotid artery below. As we can see here, this is the relation of the sphenoid sinus. You can see the sella turcica in the roof of the sphenoid. You can see the relation to the downward to the nasopharynx, anterior to the nose. It's open natural ostium of the sphenoid in the anterior wall, drain into the sphenoid recess. Its lateral relation is directed to the cavernous sinus, internal carotid artery, and the optic nerve. Then the maxillary sinus, which is the most constant sinus, it's present in all over all the population, present since birth. It's pyramidal in shape within the body of the maxilla. The apex is situated in the zygoma. The base is situated in the lateral nasal wall. The natural ostium is lie high up in the medial wall, in which it drain in the middle meatus. It got relation anterior to the cheek and the infraorbital nerve, posterior to the pterygopalatine fossa and infratemporal fossa, of course, with its content, namely the maxillary nerve and the artery. The roof is related to the orbit and the orbital floor. The floor is related to the hard palate and the upper teeth, namely the second premolar and the first molar. Remember these two teeth because we will have something to discuss about the oroantral fistula, which is the floor of the maxillary sinus. Medially, it's related to the lateral nasal wall, namely to the inferior termit and meatus, middle termit, and the middle. As you can see here, this is the shape of the maxillary sinus. Its size differ from the size of a cup of coffee to the cup of tea, from 15 centimeter, cubic centimeter up to 25. It is the largest sinus, and it is the most constant sinus. It have a lot of relation, so any disease can lead to, in the maxillary sinus, can lead to many symptoms, different symptoms. Imagine you have a tumor in the roof can lead to proptosis. Tumor in the lower part can lead to loosening of the teeth. Tumor in the medial wall can lead to nasal mass and epistaxis. Tumor in the lateral wall can lead to cheek mass and zygoma. Tumor eroding the posterior wall can lead to trigeminal neuralgia, so its relation is very important. As you can see from the figure, the ostium is high in the medial wall of the maxillary sinus, and that's because the mucociliary clearance is directed towards the ostium. So the upper part of the maxillary sinus mucosa, the cilia will direct the mucus downward to reach to the ostium, whereas the lower part of the maxillary sinus mucosa is directing the mucosa upward to reach the natural ostium, which is delineated by the arrow. Regarding nasal examination, we got external nasal examination and internal nasal examination. External nasal examination, we need to do an inspection and palpation of the nose to see if there is scar, deformity, hematoma, or if there is a tenderness or accumulation of air below the skin, which means crepitus, you feel it, or cracking in the bone if there is a nasal trauma. Internal nasal examination, that means anterior anoscopy, posterior anoscopy, nasal endoscopy, oral examination, smell testing, and digital palpation. Anterior anoscopy is done in the outpatient clinic. Posterior anoscopy is obsolete now. It's done by a mirror to see the posterior opening of the nasal cavity, the choana, and the nasopharynx. However, it's rarely used now because we got to the third step, which is a nasal endoscopy. We got the rigid and the fiber-optic one. The rigid endoscopy is used diagnostic and surgical, whereas the fiber optics mostly in the nose is just for diagnosis. Through the nasal endoscopy, you can examine all the nasal cavity, whereas the anterior endoscopy will just examine the anterior third of the nasal cavity. So the nasal endoscopy is must for examination nowadays. As regard investigation for the nose, a radiological investigation is the most important, namely the computed tomography or CT scan. Plain sinus radiography is not have much sensitivity, so just we need it during nasal fracture to obtain a medical legal report. But for a diagnosis for a patient with nasal for needing nasal surgery, computed tomography or CT scan is a must. It is what's called give us the plan for the surgery, the map for the surgery. We need it to do our surgery. As you can see, the CT scan, it is we can identify the examination. So this is CT scan, nose and paranasal sinus. We can identify the view or the cut. This is a coronal cut or coronal view because it is cope with the coronal suture. So it's very important without contrast. So it is CT scan, nose and paranasal sinus, coronal cut without contrast, showing what? Showing normal nose and paranasal sinus. Why? Because normally the nasal cavity and the paranasal sinus is filled with air. Air is in CT like plain X-ray. CT mean computed tomography. It is plain X-ray with computer. So the air will appear black. So if we see a CT like this, we this is normal CT. The abnormal part if there is an opacity, that means white or gray color inside the sinus or inside the nasal cavity. But here, this is the maxillary sinus clear, sigmoidal sinus clear. This is the inferior terminus, this is the middle terminus, this is the alternate process, this is the anterior sigmoid, posterior sigmoid. So this is a coronal view. This is very important. This is axial view. That means anteroposterior cut. Axial view. As you can see, it's showing the orbit. This is the medial rectus, lateral rectus, optic nerve. Then the posterior sigmoid, larger in size, fewer in number. This anterior sigmoid, numerous in number but smaller in size. As you can see, the intimate relation with the orbit to the sigmoid and the optic nerve. This is other cut, axial cut, showing the orbit, the anterior sigmoid cell, posterior sigmoid cell, and sphenoid sinus optic nerve relation. So this is CT nose paranasal sinus, axial cut, no contrast. This is other axial cut, but on lower down, showing the nasal septum, showing the inferior terminus, showing the maxillary sinus, the Eustachian tube orifice, the nasopharynx. This is coronal cut CT, showing the inferior turbinate, middle turbinate, and the anterior sigmoid, bulla sigmoidalis, and the maxillary sinus. We need to know this is just CT coronal cut. This is MRI of the nodal paranasal sinus. It is the negative for the CT. As you can see here, there is no bone. Bone is appear black like air. The white thing here is just the fat in the film. So it is done only if the tumor or if the inflammation extends beyond the bone and reaching the soft tissue, the orbit or the brain. So in this case, we need to know, we need to do an MRI. Other investigation we can do for nose in rhinology mean laboratory investigation and pathological investigation to do a biopsy, bacteriological investigation to do culture sensitivity test. Also, we can do rhinomanometry to judge about the cross-sectional area in relation to resistance. And this is very important to judge about the resistance in the airflow. Thank you.